Good afternoon, everyone. The whole discussion till now is going on about unhappy patients, mostly in cases of premium IOLs. But then the same thing applies for monofocal IOLs as well. I will be talking on effect of mild IOL decentration in cases of monofocal IOLs only. But before I begin with my presentation, let's revise optics of the human eye a little bit. There's an optical axis which passes through the corneal center, the vertex of the cornea, the pupillary center of the lens, the nodal point. Basically, it connects all geometric centers of the eye. There's another visual axis which passes from the object at the infernal distance and goes up to the fovea. The angle which is formed between the optical axis and visual axis is the angle alpha. Under normal scenarios, the angle alpha is 5.2 degrees horizontally and 1.4 degrees vertically. In today's scenario, angle alpha is becoming a more reliable indicator in predicting the outcomes in cases of refractive lens surgery. There is another angle, angle kappa, which is between the pupillary axis and optical axis. Till angle alpha's importance was realized, angle kappa was used to make our clinical decisions. However, the problem was because angle kappa varies a lot among patients and it is usually decentered nasally. Normal values for angle kappa is 2.6 degrees horizontally and 0.6 degrees vertically. But well, as a cataract surgeon, why are we bothered about all this? Because what we usually do is we remove a cataractous lens and place an intraocular lens. So all the relationships in terms of these optical axis and pupillary axis and visual axis should stay the same, right? But then there are different problems which arise. That's because of the centration of the IOL, which depends on state of the zonules, size of the rexus, integrity of the rexus margin, amount of capsular contraction of phimosis which happens in gradual duration, the design of the IOL, and implantation if it's in the bag or in the sulcus. Those cases where we have gross decentration, the picture is very clear because of so many symptoms that patient presents with in terms of drop in uncorrected and best corrected visual acuity, monocular diplopia, glare, photophobia, and recurrent uveitis. The treatment is very clear. This patient will surely need repositioning. But what about those cases where there is mild decentration? How do we actually define mild decentration? Well, as of now, there's no definite definition of the same in the literature. But then there have been various ways to measure IOL decentration. People have used the red glow, which is seen on slit lamp biomicroscopy to measure decentration. Based on Purkinje meter using Purkinje reflexes, it has been reported. Shine plug imaging for IOL tilt and decentration, and anterior segment OCT has been reported. In the whole conference, we've also seen the use of aberrometry, both ray tracing aberrometry and dynamic skyscopy based OPD3 scan has been used. In our center, we've been using iTrace as ray tracing aberrometer to measure the decentration of IOLs. How we did that? Actually, the entire eye is centered around the visual axis. Whenever there is an object of interest, the eye is positioned accordingly. So there is a little nasal movement and little upward movement. Similar can be seen in iTrace aberrometry if we take a dilated slit lamp picture of the patient. So the red dot here represents the visual center. The eye is actually centered on this visual axis. We can also mark the limbus manually or automatically and get the corneal vortex and hence get the optical axis and angle alpha, which is objectively measured by this machine. Whatever studies in literature say that for pre-op planning, this angle alpha should be less than 0.5 in terms of corneal intercept to get best outcomes in your premium IOL cases. But then further in my presentation, I would show you a couple of cases where preoperatively angle alpha and angle kappa both have been normal. Still, patients have come to us with unhappy visual outcome. Here we can also mark the pupillary axis and get the pupillary center and hence angle kappa. Now in all this process, the decentration or the optical center of the IOL is not measured. What we can do is we can mark the IOL optic size manually by going to selecting a disc mode and hence get the center of the IOL from the visual axis. Like in this case, the size of the disc is 6.5 mm, which corresponds to the size of the optic of the IOL. And in terms of decentration, it is around 0.219 centimeters from the visual axis. This is what are the results of an ideal cataract surgery. So in this case scenario, where the optical aberrations are to the minimal, the post-operative outcome of this patient was 6.6 visual acuity sensitivity with minimal 0.5 diopter cylinder. The modulation transfer function curve shows that this patient had good contrast sensitivity both at lower and higher spatial frequencies, and point spread function also takes us to the same. Simulated E chart takes us to that best outcome, refractive outcome which the patient had. Now, a couple of other cases, like in this case, if we actually see the dilated slit lamp examination, the IOL is very well centered in the pupillary axis, both dilated and undilated. However, there is a minimal nasal decentration in this case. Patient's visual acuity was 6.6 with plus 0.25 diopter sphere and 0.75 diopter cylinder. But when we looked at visual quality metrics in this modulation transfer function graph, for lower spatial frequencies, the contrast sensitivity was good. However, as the spatial frequencies increased, the contrast sensitivity dropped down, and point spread function also showed the similar change. This is another case example where there was slight nasal decentration, where the modulation transfer function again was good for lower frequencies, but for higher frequencies it was lost. And in terms of point spread function also, we can see that it was spread out a lot. Sterl's ratio was 0.018 in this case. This is another case example where the IOL is centered, however, the capsule has started undergoing phimosis. Here also the contrast sensitivity was lost for higher spatial frequencies, and point spread function was very much spread out, and patient was hence complaining of not good quality of vision. So right now there's an ongoing study at our center where we have so far studied 64 eyes, and we found that those patients who had decentration by more than 0.5 mm by this way of measurement had statistically significant difference between the area under the curve that we studied in modulation transfer function of the entire eye. So the decentration, even mild decentration of the IOL is an important factor which affects the outcome of our cataract surgery in terms of monofocal IOL as well. We also tried to classify our patient based on the type of IOL which was inserted, whether it was a spherical, negative aspheric or positive aspheric IOL, and tried to look at their higher order aberrations and quality of vision metrics later. So far the sample size is less, hence conclusively saying anything would be difficult at this stage. To conclude my talk, I would say, mild IOL decentration is an important cause for suboptimal visual outcome both in terms of monofocal and premium IOL patients. It not only affects quantity but also quality of vision. And using ray tracing aberrometry is a novel method to quantify decentration in these cases. Clinical application of our studies would be more futuristic. Based on this, probably trying it at multi-centers, we can go ahead and design IOLs in such a way that such mild amount of decentration should not affect the outcomes later on. Thank you.